Indeed, a real pleasure to join you all. So I'm just going to share my screen now, if the host can allow me to do that. So can our hosts allow me to screen share, please? There we go. I hope you are now able to see my screen. So greetings from England to all of my friends in that region of the world. It's wonderful to see you all and a real privilege to join you. And I'm going to talk about 5 years of Olumiant in the clinic with a focus on
Professor,
rheumatoid arthritis.
May I stop you for a second? We are just not able to see your slides. Just hold for. We are not able to see your slides.
Okay.
We are working on it.
Thank you. Please just tell me when they've fixed the problem.
Yeah, sure. I guess you can start now.
You can see the slides now, can you?
Yeah, we can see the slides, but we cannot see you. But you can go ahead.
Okay, right. Well, once again, wonderful to join you, and I'm going to talk about 5 years of Olumiant in the clinic. So here are my disclosures. And what we're going to look at is some of the key data from the Olumiant clinical trials. We're going to look at the superior efficacy that's been demonstrated with a particular focus on the RA-BEAM study. We're going to look at the remarkable rapidity of pain improvement that we've seen with baricitinib. And in fact, this is a feature of JAK inhibitors, but it seems to be particularly marked with baricitinib. And we're also going to look at the accepted and consistent long-term safety profile. And we now have data up to nearly 9.5 years of exposure to drug. So let's start off with the issue of efficacy. And this was one of the, well, it was in fact the first ever trial in rheumatoid arthritis, the RA-BEAM trial, to show that baricitinib plus methotrexate had a superior outcome according to a predefined endpoint versus adalimumab plus methotrexate. And that is illustrated on the left-hand side in a population of patients with an inadequate response to methotrexate. And you can see that based on ACR20, that there's a statistically significant difference at the time point of 12 weeks. Similarly, in the RA-BUILD study, where baricitinib was compared to placebo, baricitinib here was in a population of patients who had had an inadequate response to conventional synthetic DMARDs. That's in the middle. You can see the differential. And on the right-hand side, in some of our difficult-to-treat patients who'd failed on up to 3 or more biologic drugs, you can see that once again, baricitinib at the 4 milligram dose exceeded the efficacy of placebo at ACR20. Now, if we go into this in a little more detail, here we're looking at a remission measure in the RA-BEAM study, and from left to right, we're working through from week 12 to week 52, and this is giving us some very interesting information. First of all, it shows that both the active treatment arms, baricitinib and adalimumab, nicely differentiate from placebo, as you would expect, over the placebo-controlled period. But it also shows you that at the 12-week and 24-week time point, that there's a statistically significant and numerically higher percentage of patients on baricitinib who achieve remission than is the case with adalimumab. And the final point to make is that the proportions of patients achieving remission are incremental over time. And I think this is an important point in setting expectations for our patients. JAK inhibitors in general work rapidly. That's certainly true of baricitinib in particular. But whilst many patients will appreciate a benefit early, it may take some time for the peak response. And so it is important to set realistic expectations. Now, from the patient's subjective point of view, many features of disease are known only to them and not obvious to the treating physician, and we all know these very well. Pain and fatigue are particularly prominent among these symptoms. And what you can see in this graph is we're looking at the mean reduction in pain from baseline. These patients had a very high baseline pain of over 60 millimeters out of 100. And once again, both active treatments differentiate from placebo, but baricitinib baricitinib differentiates from adalimumab at an early time point at week 2, and this difference is then maintained and statistically significantly different throughout 52 weeks of dosing. So this was really remarkable finding, and actually an unexpected finding. We were so intrigued by this, and what I've just shown you is the mean difference, that my colleagues and I decided to look to see what the difference was on an individual patient basis. So we actually looked at thresholds of 50% improvement in pain from baseline, and even more than that at 70% improvement. And at each of these thresholds, there were numerically more patients on baricitinib plus methotrexate achieving these thresholds than was the case with adalimumab. Furthermore, baricitinib achieved this in half the time. And if you look on the left-hand side of the histogram, you can see that nearly 50% of patients on adalimumab had an absolute pain improvement that took them down to 20 millimeters or less, which implies that effectively the pain had resolved in those patients. Now, we all know as well that in rheumatoid arthritis, there's a close correspondence between pain and physical function. And here you can see the data for physical function, that in fact, both active treatment arms differentiate from placebo, but baricitinib performs better than adalimumab. So again, a very useful improvement in physical function. And one of the other features that's of concern to all of us is whether an effective therapy will have a sustained benefit over time. And this is particularly important because we've learnt over the years that many of the biologic drugs lose effect over time, and this is in part related to immunogenicity. So with this particular graph, you can see that from 6 months onwards, the placebo patients are crossed over to baricitinib, and from 52 weeks onward, the adalimumab patients are crossed over to baricitinib. And in fact, the responses are beautifully maintained over the long term. We published this last year, and you can see that by the end of 3 years of treatment exposure, over a third of the patients can be expected to have achieved remission by a stringent criteria. Now, structural damage is another very important point. In my country, we see much less structural damage today than was the case a generation ago. But here you can see the probability plots. And in fact, what this is showing us is that irrespective of the initial treatment assignment, of course, all the patients end up on baricitinib after a certain period of time, you can see that there's very nice inhibition of structural damage that is maintained over 5 years. And in actual fact, about 80% or more of the patients are not progressing at all over that time period. So this is very important observation. Now, when it comes to drug options in rheumatoid arthritis, in my opinion, having flexibility of dose is an extremely valuable attribute. And baricitinib has 2 doses available, 2 milligrams and 4 milligrams once daily. And this gives us the opportunity to titrate the dose where required. We've also seen from the baricitinib program that it works very well with or without methotrexate. I think there are benefits in keeping methotrexate on board if the patient tolerates it, even a low dose of methotrexate, but nonetheless, JAK inhibitors in general and baricitinib in particular are recommended as one of the choices for those patients who can't tolerate methotrexate. We've also learnt that drug holidays are possible. For example, if a patient has a minor infection or a major infection, you can temporarily stop the drug without loss of response and reinstate the drug later on. And this is one of the advantages of a short half-life small molecule. We've also learned that we can dose taper from 4 milligrams to 2 milligrams in those patients who have a sustained low disease activity state or remission. So there's quite a lot of flexibility associated. And here's an example of the study that we published a couple of years ago. So patients who were in sustained low disease activity over time, some of them were randomized to reduce the dose from 4 milligrams to 2 milligrams, and you can see that about 80% of the patients maintained their low disease activity or remission state. Nonetheless, for those 20% of patients who lose their low disease activity or remission state, there's the option to reinstate the higher dose and then they recapture disease control. So flexibility, I think, is a real positive attribute with baricitinib when it comes to dosing. Now, we've looked now at data up to 9.3 years of exposure in 3,770 patients across multiple clinical trials, and this represents over 14,000 cumulative patient years in all these different studies. So let's have a look at some of the key headline data. Well, we looked at the data over this time period and found no clinically significant differences observed in the incident rates of key safety measures between the two doses on average, the 2 milligram or the 4 milligram dose, and indeed placebo. And that includes serious infection, malignancy, major adverse cardiovascular events, and DVT and PE. So these are important attributes here. And so what we are seeing is that the expected background rates are not exceeded in the clinical trial context. We've also looked at the incident ratios across safety measures, and they've been found to be similar to those that have previously been reported in integrated safety analyses. In other words, there doesn't seem to be an effect of cumulative exposure to drug in increasing the incident rates of adverse events. Looking at deep vein thrombosis or pulmonary embolus, the rates were again similar between the 2 and 4 milligram dose groups and in the extended data set, and we're going to look at that in a little more detail. So let's have a look now. So if we look at serious infections, there you can see the data with the exposure-adjusted incident rates for pneumonia, zoster, urinary tract infection, and cellulitis. And these are some of the most important events to note, but please note that these are rare events when you look at the exposure-adjusted incident rates. If we look at other events that are not necessarily serious, including herpes zoster, then in fact you can see the incident rates for all zoster, which is predominantly non-serious and monodermatomal. It's actually 3 per 100 patient years. So it is a little higher than you would expect with anti-TNFs. You can see that 94% of the cases were mild to moderate in severity, most resolved without problems. But it is also important to note there's an ethnic variability. So patients from Japan, Taiwan, and Korea have particularly high rates, almost double those in white Caucasian populations or from our colleagues in the Middle East. No visceral cases were observed in the studies, which is obviously very good news. So when we look at this issue of venous thrombotic events, I think it's been a challenging and controversial issue. And here are some epidemiological studies. And if we look at the rates of baricitinib VTE, you can see they fall right in the middle of the reported background rates. So that's for venous thrombotic events as a whole. This is for pulmonary emboli with a rate of 0.2 per 100 patient years, and for deep vein thrombosis, 0.3 per 100 patient years. So there's no increase over the expected background rate. But nonetheless, it means we have a responsibility to look at those patients with baseline risk factors, of course, and we all know what those baseline risk factors are. So here you can see the issue of cumulative exposure to baricitinib over time, and progressing from left to right across this slide, you can see increasing exposure to drug with the overall rate at 0.5 per 100 patient years. Of course, the confidence intervals get wider when we come to the more recent data cuts because the numbers of patients involved become relatively small, and that's why you see wide confidence intervals. Here's a comparison of the 2 and 4 milligram dose in the data sets from the 9.3-year exposure data. And really a summary of this data is that there doesn't seem at an average level to be any very obvious difference between the 2 and the 4 milligram doses, and I think that's reassuring. Nonetheless, based on common sense, if you had an elderly patient who was vulnerable with comorbidities who was in remission on the higher dose, of course it would be very sensible to consider reduction to the lower dose. And it's not only important to look at data from the clinical trials, which I've just presented to you in some detail, but we need to see whether real-world data corroborates the findings of the trials, because clinical trials exclude many patients that we would see in everyday practice. So here we're looking at data from registries, which have higher numbers, less granular data, but the ability to explore relationships between rare adverse effects and the drug exposure, and also to explore whether the efficacy outcomes are similar in real-world practice to that seen in the trials. And here's some data from our colleagues in Switzerland. They keep very nice databases. And what it's showing, really very compellingly, is that baricitinib has a higher survival of drug, which you can see in the orange colored line at the top of the left-hand graph. And that is statistically significantly greater than with anti-TNFs. Other mechanism of action biologics, interestingly, come somewhere in between. And that's probably because the mechanism of action has some effect on the B cell compartment. And of course, that can diminish antibody responses to the administered biologics. So we see very nice and sustained responses with baricitinib over time and a very high drug survival, which is probably reflecting the lack of immunogenicity of a small molecule. Another study that's going on at the moment, and you may have seen some of the first data at the ACR Convergence meeting. I believe there'll be more data shown at EULAR this year, if any of you will be watching or present. And this is from the so-called RAB-REAL study. Now, this is an observational open label study in which patients are randomized to one of two cohorts, either baricitinib at one of the two approved doses or other biologic or targeted synthetic DMARDs. And this is just a teaser to show you some of the data that came out of ACR Convergence. And essentially, if you look at the cohort A, which is the baricitinib cohort, you can see that fewer patients discontinue drug than was the case in cohort B, which I'm just highlighting now. So once again, this corroborates good survival on drug, which reflects high efficacy, good tolerability, and lack of immunogenicity. And if we look at the most important outcomes, and here you can see remission highlighted, there is a higher proportion of patients who achieve remission with baricitinib in real-world circumstance than is the case with other targeted therapies. With respect to safety, again, it's important to see how the safety issues compare between the clinical trials and the granular data with the less granular real-world data. And here we see some comparisons. So looking between Japan and the 9.3 data from the trials on the left, you can see again they're very comparable. The difference, however, is in serious infections, where they're a little higher in Japan. And don't forget that the zoster rates, of course, are also higher in Japan, because the Japanese population are more susceptible. If we look at some of the other registries and look at efficacy outcomes, you can see actually they're broadly very comparable in Germany, Spain, Switzerland, between the clinical trials. If anything, the rates are higher for efficacy in real-world practice, and this is probably because it's not necessary to recruit patients to start drug with such a high baseline disease activity, as was necessitated by the trials. Looking at the efficacy and safety from an Italian study now. This is a recently published study that some of you may have seen. Again, one of the facts that this particular study shows is how nicely steroid-sparing Olumiant is, and indeed how patients can withdraw their glucocorticoids, which I think is an important consideration. We've been encouraged in the past to use steroids as bridging therapies, but we've realized now, and there's a very nice paper published very recently that shows even a small dose of glucocorticoids is very detrimental for cardiovascular health and infection. So where we can withdraw steroids or reduce the dose, that's a highly desirable thing to do. In terms of other efficacy outcomes, baricitinib performs extremely well, and very similarly to that we've seen in the clinical trials. Again, in the Italian data, the drug survival is really very impressive, as you can see over on the right. And if we look at the baseline demographics, you can see that these are the type of patients we would all see in daily practice. With respect to efficacy and safety, looking from left to right across this busy slide, you can see the remission and low disease activity figures, and again, just how well baricitinib performs, and performs extremely well compared to other drugs in their registry. And you can see a nice reduction of disease activity over time. And again, a reminder that it may take some time for the maximal reduction for certain patients, but overall, this drug works with remarkable speed. And looking on the right-hand side, we're actually looking at data for pain, which corroborates what we've seen on the clinical trials. And if we look at ultrasonographic data, this is very important. Our Italian colleagues are very keen on using ultrasound. We can look at the gray scale, which reflects synovial thickening, but also look at power Doppler, which is showing vascularity and activity within that synovial tissue. And where that's associated with a cortical break, there's a very high risk of bone erosion. So to look for power Doppler and the suppression of power Doppler is very interesting from a research point of view. And in fact, we can see this rapid suppression of grayscale and power Doppler signal on the left-hand side in the histograms. So there are a number of take-home messages here in this brief talk that summarizes some of the remarkable data that has emerged since baricitinib was launched 5 years ago. This is a new therapeutic, and obviously the mechanism of action is JAK inhibition. It's a JAK1/2 selective inhibitor, and that in itself is interesting because GM-CSF signals through JAK2 homodimers, and this may explain part of the very nice efficacy for pain and other attributes. We've seen that baricitinib has shown superiority to adalimumab in the RA-BEAM study and consistent outcomes across populations, including real-world data. We've seen very nice data for long-term maintenance of efficacy, not only in the trials, but also in real-world data, and a very rapid onset of action. But nonetheless, there's some patients who may take some time to achieve the maximum response. We've seen nice inhibition of structural damage, in fact, up to 5 years. And in my view, a very useful attribute of this particular drug is its versatility of dosing. Having 2 doses available is very valuable, and it can be used in monotherapy or combination therapy. The safety profile has been shown to be very manageable, and many of the potential risks we can mitigate, of course, and we've talked about the superiority issue. So I'd like to thank you very much indeed for your attention, and I'll stop sharing my screen. And then by the magic of contemporary technology, perhaps you can see me again and I can see you. So it's wonderful to join you. Thank you.